Welcome to the Next Step in Care learning series. This video is designed to provide healthcare and social service providers with ideas and guidance on ways to work together with family caregivers.
Okay, here's a listing of examples of drug categories and drugs associated with preventable adverse drug events. So these are the things that could possibly occur when these drugs are taken. So what you could then do is either avoid these drugs whenever possible or use them in such a way that you're actively monitoring for the onset of any potential ADE. So it's not always possible. It is possible to reduce the use of NSAIDs in the elderly. There are options. The options are usually the opiates. But you can use them in a way that's a stepwise fashion that reduces the incidence of adverse events. So what you would probably start with for pain control is acetaminophen, if patients can tolerate that, if they don't have liver function problems. And you would start with a dose that's appropriate, that's routinely given. And you know, in patients who have dementia, they may not be able to tell you that they have pain. So using a stepwise approach to pain control is very important. Using the drug routinely, the acetaminophen or Tylenol routinely first, and seeing if that resolves the problem, and then moving up slowly into the other drugs. There was just a paper that was published, it was Ballard, by Ballard in British Medical Journal regarding, I think it was 2011, and it was regarding a stepwise approach for pain management in patients with dementia. And that it helped reduce pain in these patients and reduced agitated behaviors. You know, so they had a good response to that. Antibiotics can always cause some kind of problem. They're always a risk for various problems. There could be CNS, central nervous system problems, rashes, skin eruptions, drug interactions, huge, and GI and cardiac events. So anytime an antibiotic is started in any patient, but particularly the frail, vulnerable, elderly with dementia who maybe might not be able to communicate this, we should be monitoring for these events actively. Anticholinergics, we spoke about that. Anticoagulants. Warfarin can cause bleeding, and there's a lot of drug interactions, i.e. with antibiotics. We have a program at IPRO where we encourage our collaborative partners to have patients who are on warfarin and who are prescribed a concomitant, at the same time antibiotic, that they get a blood test, an INR, that measures the thinness of their blood within 3 to 7 days. Get that INR done within 3 to 7 days. So within that next week of an antibiotic, they should, so on transition, this is particularly important that a patient get that lab done in that week after discharge from the hospital. And when we're working with hospitals to try to get anybody who's on warfarin to have an INR within a week after discharge, to avoid the readmission due to bleeding, which does occur fairly expensively and often. Heparin and other anticoagulants are also often on a patient's profile on discharge, and they can cause bleeding or other blood disorders. Digoxin is a problem. It's a great drug for certain people. It works very well. However, we often see that it might be dosed inappropriately for the elderly. It might be dosed too high. The blood levels may be elevated, especially on discharge from the hospital. When I did home care, I used to do home care visits and medication reconciliation in the home for a Visiting Nurses Association. And I encountered this pretty frequently, of digoxin toxicity within the week that patients were discharged home. So I would always encourage getting blood levels. Symptoms of toxicity or GI upset is normally what you would kind of see first: nausea, diarrhea, visual disturbances, if they can report that, and a low heart rate. And then you have diuretics, which are a problem. So you often have people who are on digoxin and furosemide, and furosemide is a diuretic. And so that may cause hypotension, so it's low blood pressure, or also diuretics can cause loss of potassium. Loss of too much potassium in the presence of digoxin can cause low heart rate. So you can potentiate that digoxin toxicity, which is problematic. So these are all serious issues that can occur in that vulnerable transition time. And then central nervous system agents, we know that benzodiazepines can cause sedation and falls. I think everybody in the room knows that we should avoid benzodiazepines if possible in the elderly, Valium, Xanax, etc. Antipsychotics are a real issue. It's a hot button issue now. It's starting to get a lot of federal attention now. The QIOs, I work for a quality improvement organization. We get money from Centers for Medicaid and Medicare Services to work on reducing adverse drug events. That's one of the projects that I work on. And we're starting to see more interest in the antipsychotics and reducing them in nursing homes. We have nursing home practitioners in here, or just hospital? Any nursing home? Or we have, okay, so you're aware, you know all about the antipsychotic issues. And then some have anticholinergic effects, but also they're associated with stroke and death in patients who have dementia. And then drugs that reduce blood glucose, like insulin and sulfonylureas, can cause low hypoglycemia, so low blood glucose, and they're associated with increased hospitalizations. So the drugs that are associated with increased readmissions are this group, the hypoglycemics, warfarin, and the opiates. They're all associated with increased rehospitalization. NSAIDs should be avoided in the elderly. I kind of flipped by that, but they worsen renal function, they cause salt and water retention, they increase blood pressure, they can exacerbate heart failure, so they're a real problem too. And then I added this, adverse drug reactions or events, and you'll see here that independent risk factors for falls in older adults. Look at this whole list here are medications, this whole list here. And this is also part of your strongest risk. So that's why we look at medications as the root cause first. Okay, so what do we do with antipsychotics in the elderly? Antipsychotics should not be used. There is a lot of pressure to stop their use because of their adverse events and because of all these issues. So we need to look at ways that we can help patients with dementia who have agitated behaviors, which I don't really like that word, agitated behavior. So what's the specific behavior? So they have behaviors that are outside the norm of what's socially acceptable. Is that another good definition? Not sure. But they have wandering issues, as we spoke about before. So there was recently a systematic evidence review of non-pharmacological interventions for behavioral symptoms of dementia that was published in 2011. And they kind of looked at all of the well-done randomized controlled trials looked at these trials and determined which ones showed some kind of effectiveness or not. And there's really no clear-cut yes or no, you should use this or you shouldn't use that. Basically, it's individualized care for the patient. So, but what they did find was that there was evidence leaning toward massage, music therapy, aromatherapy, exercise, use of animals, etc. Aromatherapy can go anyway, it depends on the resident. So people say, oh, use lavender. Well, not everybody likes the smell of lavender. It may turn some people off. I remember I was working in one nursing home when I used to consult, and there was a study that was being done by an outside agency coming in, and they looked at aromatherapy, and this was in the mid-90s. And they had an apple scent on the bracelet, and then they had an earth scent, like a freshly turned earth scent. And this was a rural community, and the men who were in the study, who were farmers, responded to the freshly turned earth scent, not to the apple scent. So you can see how highly individualized. 2 weeks ago, I just found out about it last week, and so I threw it in. It's non-pharmacologic management of behavioral symptoms in dementia, and it's a nice little article. It starts with a case study, and it brings you through the case study of a patient with dementia, and it provides these nice tables of strategies for managing behavioral symptoms. So, introduce activities that tap into preserved capabilities and previous interests. So it gives guidance on what a caregiver can do, what kind of activities the patient with dementia might respond to, how you should communicate with a patient with dementia, and what the environment should look like, and how to simplify tasks. So I threw that in there for you, but the article is also in your folder. Medication adherence factors in dementia. I threw the slide in not so much for the adherence issues, but to reinforce that there's an impaired executive function issue with patients in dementia, so they have difficulty starting or stopping an action or adapting or responding. And I'll tell you a story. In my household, I have my 86-year-old mother who's got moderate dementia, and we built a house, and I built a section in the house for her. So she's got her own living area. And so she has dementia. My son has Tourette's syndrome and OCD. So she repeats things all the time and has difficulty starting, stopping an action, or adapting and responding because of dementia on one side of my house. And I have my son on my other side of my house who repeats himself constantly and has difficulty stopping and starting an action and adapting and responding. It's really kind of very yin-yang-y in my house sometimes, you know, so it's very strange. Anyway, personality traits in patients with dementia who have medication adherence problems are those who are highly independent and have high self-confidence. They mask the fact that they may not be able to take their medications. So these are people you might want to target for really in-depth with their caregivers of how well are they really, is the patient with dementia taking their medications, and should the caregiver institute some extra support. Some of these people do have a lack of social support because they push people away because they are too self-confident, and also patients with dementia, 2 weeks after their hospital discharge, there's a 2 to 3 times increased risk of them taking either greater than 30% less medication than they should, or greater than 20% more medication. So they're at high risk in that 2-week period, so they need more intense monitoring at that time.